Today I will demonstrate how to perform an inferior glide of the hip joint with and without physiological motion. This manual therapy technique is warranted when a patient displays pain, limited movement, and dysfunction of the hip with flexion when flexion is involved. The Maitland joint mobilization grades indicate the type of oscillation appropriate for various population groups. Grade 1 is a small amplitude rhythmic oscillation in early range of motion. Grade 2 is a large amplitude rhythmic oscillation in end range of movement. Grade 3 is a large amplitude rhythmic oscillation to the point of limitation in end range movement. Grade 4 is small amplitude rhythmic oscillations at end range of movement. When used properly, mobilization has been found to reduce pain, increase range of motion, and improve overall function in the patient with hip dysfunction. The primary goal of mobilization is to restore accessory motions necessary for normal open and closed chain arthrokinematics of the concave and convex rule and kinematic movement. Here we have a model of the hip, which is a ball and socket joint that articulates the acetabulum of the pelvis and the head of the femur, allowing for all degrees of freedom to occur. The acetabulum is positioned in a lateral, anterior, and slight inferior direction, where the head of the femur is positioned in a medial, superior, and anterior projected direction, giving a smooth articulation of the joint surfaces. This particular joint plays a major role in the function as it bears load from the upper extremity as well as the ground reaction forces from the lower extremity. Now I will demonstrate an inferior hip glide without physiologic motion. Your patient will be placed in supine with the leg needing mobilized closest to you. I will place the leg over my shoulder with the knee flexed, making sure that my body mechanics are appropriate. You can also incorporate abduction, adduction, or internal and external rotation depending upon where you find the restriction. Stabilization is provided by the patient's own body weight. You can also use a stabilizing belt. Next, you will clasp your hands together over the anterior aspect of the proximal femur with your forearms in the direction in which you want to apply the force. Then apply an inferior directed mobilization force using your full body. So it'll look something like this. Now I will perform an inferior glide of the hip with physiologic motion. The patient will remain in supine and the hands remain on the anterior aspect of the proximal femur like before. The force will be applied in an inferior direction as the counter force is elicited distally through the therapist's shoulder. In a scooping motion, the hip is then brought into a more flexed position. This force is maintained throughout the entire range and sustained at the end range. So I'll show you now. Now what we just did was an inferior glide to the hip. This will help reduce your pain and improve the range of motion that you are restricted in right now. A study in 2013 in the Journal of Orthopedic and Sports Physical Therapy measured femoral translation glide in vivo during posterior hip mobilization in order to interpret the normal arthrokinematic glide necessary for hip flexion. Results showed the average translation glide was 2 millimeters and required average for passive range of motion of the hip was an average of 53.8 millimeters, meaning the translation glide at the hip are small in amplitude and only represent a small amount necessary for normal hip flexion. It is suggested that angular mobilization should be implemented for restoration of movement. A limitation of this study was the healthy subjects were used. Results can differ in the quantity of movement experienced with mobilization in patients with hip dysfunction. Manual glide techniques are beneficial for patients in physical therapy. A study in 2007 in the Journal of Manual and Manipulative Therapy investigated the effects of grade 4 inferior hip joint mobilization on hip abductor torque. This study determined a significant increase in hip abduction torque in the grade 4 group and a decrease in the control grade 1 group. Results show grade 4 improved strength immediately post-intervention in healthy individuals. This demonstrates the benefits of joint gliding and correlation and activation of the hip abductor muscles, which could be used in physical therapy with a patient displaying these deficits. A study in 2013 in the International Journal of Sports Physical Therapy has established that restricted hip mobility has a correlation with pathologies associated with the hip, lumbar, and lower extremities, which can lead to greater issues in the kinetic chain. Integrating self-mobilization into home exercise programs with strengthening exercises found optimal improvements. The goal for self-mobilization was to increase capsule and connective tissue mobility and improve muscle re-education. This study states before self-mobilization to perform stretching, then perform dynamic exercises to re-educate the musculature to assist with maintaining the newly gained range of motion. There still needs to be more research conducted on self-mobilizations to see long-term benefits.